Stay. Lay down. Lay down, puppies.
Hello, everyone. We will begin in about 1 more minute. All right, good afternoon, everyone, and thank you for joining us today for the webinar on Medicaid billing and coding update, specifically the E&M codes, hosted by HCET with our presenter, Kyle Robel. And my name is Megan Arias. I am a training manager at HCET, and I will be moderating the webinar today. So let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. For more information and to keep up to date with HCET events, please be sure to follow HCET on these various social media platforms and visit our website at hcet.org. And for additional training and professional development opportunities, visit our virtual learning website at learn.hcet.org. So now I'll quickly go over some housekeeping information. A link to complete an event evaluation will be sent to you via email following this webinar. Your feedback is greatly appreciated. And you can find archived webinars and presentations and a list of upcoming events on our website. And if you have any technical difficulties during this presentation, please contact myself at the email that is listed on your screen. So throughout the presentation, we encourage you to send your questions via the chat box. And to submit a question, you're going to hover over the main screen and then select the blue chat icon. And once that's selected, a chat box should appear on the right side of your screen. And to send a question at any time during the presentation, please send it to all everyone so that those who need to see the question can view it. And we will hold all questions until the Q&A portion of the presentation. So now I'd like to introduce you to our presenter today. Kyle began working in healthcare in 2009 as an intern at UW hospitals and clinics in the Nursing Resource Center. And during that time, he was the founder and president of the Health Administration Student Organization at UW-Madison. Then he co-founded an in-home senior care company, which provided non-medical services to elderly and disabled patients. He moved to Durham, North Carolina, where he worked briefly at the Duke Medical Center in a clinical setting as an office assistant. And he did a great deal of volunteering and outreach with the homeless community in Durham. He returned to Madison as a freelance journalist covering stories for Quarterly Nursing magazine, along with various other publications. In 2014, Kyle began working on the Wisconsin healthcare account for Hewlett Packard, and he worked in several business units, including provider enrollment, claims mailroom, contact center, and finally, provider relations. He has been in his current role since 2016 as a field representative / trainer on the provider relations team. And he handles outreach, trainings, and escalated topics for Medicaid providers in Wisconsin. So without further ado, I will be handing things over to Kyle.
Thank you very much, Megan. So yeah, it's just to clarify, those many people don't know, and I certainly didn't before I joined the Wisconsin healthcare account. The state of Wisconsin has a fiscal agent that manages the Medicaid information system. And so that used to be Hewlett Packard. We have changed names multiple times since then. But bottom line is that the account has been held by the same, the same account, the group I work for, even though our company has been bought and sold a few times for about 50 years. So, and yeah, what I do for just a little more background about what my place is in Medicaid is I work with providers on claims and PAs and enrollment and escalated policy concerns when there are issues that come up. And then another large part of my job is to educate providers and other stakeholders on Medicaid policy, new policy that is being launched, such as these changes that were adopted by Medicaid in regards to the evaluation of management codes. So if you want to, if there's something that I'm talking about and you want me to explain a little bit further in more detail, feel free to jump in the chat room and let us know. Otherwise, like Megan said, we can, we're going to leave some time for Q&As, just so that we can, make sure we're covering the topics that the group is looking for information on. Okay, so I'm going to share my screen here in a moment once I minimize all the non-pertinent parts of my laptop that are up. Okay. And I'm going to start out with, because today we're going to be covering, excuse me, we're going to be covering the E&M codes that hopefully y'all can see my screen now. We're going to be covering the E&M codes that are kind of changing. There are a few specific questions that came up, and then there's kind of an outline of the topics that we want to cover. And I think the best place to start is this update. So a little bit of background, at the national level, changes were made to the E&M code set, and ForwardHealth adopted those, and they are effective as of 1/1/2021. There's one code that was removed, and then some changes to kind of the methodology behind using the codes for the other codes that are in the E&M code set. ForwardHealth released this update in January of 2021. Goodness, it's almost spring now. I keep seeing that it's almost March, and it just blows my mind. So we released this at the beginning of the year, and it's kind of a twofold situation. The way to use E&M codes is both changing and not changing. And so I'm going to kind of go through this update a little bit, which will offer some background and then some details on the specific codes. And then I'll cover some of the topics and provide a few resources for you as providers to be able to kind of answer some of these questions that we may not be able to get to. So the big thing, as I said, these changes are a federal, we're adopting federal guidelines, and you can view the background of where this policy came from in a few different ways. I brought up a few of the different a few of the different things that have been published regarding the E&M codes. And one of those is through AMA. There's also a few other AAPC and then CMS. CMS released a documentation guideline for 2021, documentation guideline document that's really helpful. One of the questions that came in just today actually was how to document E&M codes so that, you know, when it does come time for that audit, that you're able to kind of confidently understand what was expected of you, and that you don't get any recoups. And so it talks about that right here on the update, but I suggest checking out that CMS website for the 2021 documentation guidelines that talks about, you know, what the requirements are for the 99202 to 205 and then the 99211 to 215 codes. Okay, so effective January 1st, we will no longer be allowing 99201 to be reimbursed. Additionally, effective 1/1/21, you can document E&M outpatient visits 202 to 205 and 211 to 215 using either medical decision making or total time to choose the visit level. So this total time aspect, and we'll show you the chart that's listed here in the update in a couple minutes, but that's kind of the major change. It's the methodology behind which level of E&M service you're choosing. So I'm going to come down a little bit further. So revisions to these procedure codes include the total times, which include both face-to-face and non-face-to-face time. That's something that's come up a few times. You know, does that mean it's just the time we're spending in the, or that the physician is spending in the room with, or the healthcare professional, don't mean physician only, is spending in the room with the patient? And it's not. It includes face-to-face time and non-face-to-face time. Total time incorporates the time spent on that date of service, though. Separately reported services may not be included in the total time calculations, and that's something that there is more information listed in this update, as well as some of those other websites that I mentioned. The AMA is a really helpful website as I was going through kind of what the changes are and how to incorporate that into decision making at the clinic level. Okay, and then also effective on 1/1/21, we're adding the HCPCS code G2212, which is going to be used for prolonged services, and that will include with or without direct patient contact as an add-on procedure code to 205 and 215. The G2212 will use total time with or without direct patient contact for that date of service again. It must be based, the primary code, it must be based on the total time to use this add-on procedure code. So that's that difference between the decision-making, medical decision-making, and the procedure and the time. And so G2212 will be used once for each 15 minutes past the primary service time and may not be used for any time unit less than 15 minutes. The procedure code 417 will not be covered as an add-on procedure code to 205 and 215. And again, if you have a service that's separately reported, it can't be included in that time calculation. It can't be submitted on the same data service as the 993, 54, 355, 358, 359, 415, or 416. And so that's something, you know, that you'll have to keep in mind. There are some changes in the vision service area, but I'm going to skip over that as it's not necessarily pertinent. If you are curious, there's more information in the Vision online handbook on E&M services. Okay, so in the documentation section here, excuse me, we talk about what is required. And it's something that every provider, when you sign off with Medicaid contract, that you're agreeing to this. One of those things that most people don't see, and if they do, they don't necessarily read all the way through. But this is just one of them. You are required to meet a certain level of standard for documentation with Medicaid. So when using the CMS 2021 documentation guidelines for E&M codes, you're required to retain in your records whether you're billing using the medical decision-making or time based on the CPT guidelines. That's the big one. So you just need to, in the time, it has to be signed off and it needs to be explained whether you're choosing to use the MDM or the time methodology for level of E&M code. And of course, it needs to be able to justify what code you used. That's a big one. And I think one of the questions I get from providers is, well, how do I determine kind of between the levels, if I'm using the medical decision making? And I think that's something that at a billing specialist level, you need to be able to comfortably, read the AMA website, understand the CPT handbook. It's not something that I can really point you to. Now that we have this time-based system where I can say, specifically, here's the time requirements that allows you to choose a code. It's a little bit easier, but it's still something I think that professional billers need to be comfortable with. And so if you're a clinician, you should be able to work with your biller to, understand which one you're going to be using. A quick note that this is fee-for-service policy. Managed care policy is different. It may or may not be different. Not all managed care HMOs require the same billing policy. Okay, so I saw a chat came in. Let's just see. Okay, so Chris, thanks for pointing that out. And Tia, I see, would that documentation be for every encounter? Yeah, every time you bill an E&M code, you need to be able to justify the use of that code. And so it needs to be something, I think for you specifically, and for people who are, unsure about what the level of documentation should be, should really check out that 2021 guideline for E&M services. It's a little lengthy, but there are a lot of bullet points that show exactly what is required. And if we have time at the end with the Q&As, I can bring that up and kind of go over the high level. For those of you who don't have professional billers, of course, and you're not alone, there are many other service areas that that the clinician themselves, independent mental health providers and chiropractors specifically come to mind, where after they're done with their visits for the day, they put on their biller hat. And of course, that's unfortunate because medical billing is mind-numbingly complex. And, as a clinician, you should be able to, focus your energies on what your main purpose is. For those of you who don't have professional billers, I think, the big thing is when you have questions, if it's a specific situation, you have resources. I end every training I do with providers the same way, and that's, if you take away anything, take away my contact information, because that's what I do. I work with providers day to day on questions they have about working with Medicaid. So while we go through this, just keep in mind that if you have any questions, you can reach out to me or another field rep. We've got 12 other people on our team who just work with providers. So, don't feel like you're going to be kind of left in the wind in that sense. You've got resources that will back you up, and yeah, so that's my big takeaway. But I'm going to keep going here. Okay, so in the first attachment of this update, it lists out what the codes are and then it talks about a brief description and then what the MDM and the total time are for choosing that code. And so obviously we removed the 201 and 202. And for those of you who don't know, the 202 is going to be, well, 202, 203, 204, 205 are going to be new patient codes. And then the 1, 2 and up are for existing patients. And we'll talk about 211 because I know that's another question that's coming up a lot. Okay, so 30 to 44 minutes, 15 to 29 minutes is your standard 202. 203, 30 to 44, low medical decision making. Moderate, 45 to 59 minutes. And then 60 to 74 or high medical decision making for 99205. And then we get to the one that is kind of a question mark for some people. So 99211 is office or other outpatient visit for the evaluation and management of an established patient that may or may not require the presence of a physician or other qualified healthcare professional, usually presenting problems are minimal. What I can say about this code is what our system says about it. Once I finish with this update, so that we're not bouncing back and forth between screens, I'm going to go to the fee schedule and I'll show you what the allowable provider types and specialties are. And then I will also show you the back end of our system, which has a little more specific details about what's allowable and when this code will pay or not. So 212, excuse me, starts back over with straightforward 10 to 19 minutes, and then it goes up 213, 214, 215 from there. Megan, can you stop me if any of those chats are something I should stop for, or if it's something we can wait on? If it's about, specifically something I'm covering, I don't mind stopping.
Yep, I can do that.
Thank you. And then here's the description of the 2212, the G2212, which is a HCPCS code. And that's something for those who don't have professional billers. It's just a different set of codes, but we're using that one in this case as the add-on. And here's your time. Okay, so the next section or attachment here, again, as of 1/1/21, the CPT procedure codes 99, 345, 55, 358, 359 will be revised. 354 and 55 will apply to the outpatient setting only and will no longer be allowable as an add-on procedure code with outpatient office visit codes, the other codes we talked about. The new HCPCS coding G2212 is going to be that add-on code. And again, FYI, it can't be used on the same date of service as those other prolonged services code. And so here, just a brief description of what those prolonged service codes are and the time allotment for choosing which one to use. Okay, so that's going to be enough for the update there. What I'm going to do now is jump over to the online handbook, or I'm sorry, not really the online handbook, to the ForwardHealth portal. And I always like to just do a brief kind of overview when I'm talking to providers. The home page of the portal down towards the bottom is where we keep kind of the most important things. Updates, that's what we just looked at. That's where we first publish any new policy. That policy update gets combined into existing policy, and it's all stored in our policy repository, which is the online handbooks. So there's 2 online handbooks that will be pertinent for family planning clinics, and that's the Family Planning Online Handbook and then the Family Planning Only Services. The FPOS handbook kind of talks about some specific things, and both should be familiar for those of you who are working, with Medicaid patients in a clinic, family planning clinic. It's where we talk about not only these E&M codes in depth as well, but all the coding information. So for those of you who don't have professional billers, should become familiar with, I'm going to jump to another tab here, should become familiar with this section right here, the code section, where it talks about the different allowable codes under the family planning service area. The next thing we have is the forms library, and that's kind of self-explanatory. Beneath that, there's a couple other links. The most important one for a newer portal user is the user guides, and that is step-by-step instructions that, if you're new to submitting claims, it's a step-by-step instruction on how to submit a professional claim. Of course, there's a lot of variables with claims, so it'll only get you that far, but it still is a good place to start. Trainings is where we post all of our upcoming live or webinar-based trainings, as well as trainings that we have recorded. Over the next year or so, we've got a huge change coming up. We're using a new system, and we're going to be publishing a lot of smaller videos, 2, 3, 4, 5-minute videos that cover specific topics, and you'll be able to look through a catalog of them. And so coming up, especially for newer users or users who aren't as comfortable, that's going to be a great spot. We currently have several videos posted, but keep tuned for more information in that link. And then the bottom one is an email subscription. If you aren't already subscribed to email subscriptions, you should be. It's where we can communicate policy changes and updates and other things to providers. Okay, so what I wanted to show you now next is the fee schedule. And this is going to show us a few things. Some of the questions that have come in regard what codes can be performed by what providers. That 99211 is something that in the description, it's pretty vague on who's allowable to bill that code. And so this is going to tell you what I can tell you about that code from, a Medicaid technical assistance perspective is who can bill it. And so we'll start with that one. You'll have to, yep, go ahead.
All right, there's a question in the chat that asks, when you say new system, what are you referring to? I think that's the answer to that question.
Yeah, we have an LMS. It's a learning management system. It's just going to be kind of a new platform by which we can publish and distribute trainings. We're working on the specifics right now, but the best case scenario is that we have different courses set up for different topics, and providers can go through different courses to become proficient at different parts of the portal. So it's just a learning management system platform, and it's something that we're in the process of building right now. Okay, so the max fee details here, I'll go back and talk through it because it's important you know how to do this. From the home page, as well as from the provider homepage, if you click the provider icon, you can get to the fee schedules. So if we press fee schedules, it comes to the home page of the fee schedules. The drug search tool is available. A link is available from here. The downloadable fee schedules are available from here. And then the interactive max fee search tool is what I'm going to be showing you today. That's where you can individually research a specific code. It's a little confusing once you get to the service area section, and that is because we sort this based on the contracts that different providers have. So for the E&M services, it's billed under the contract med services. So that is the service area that we're going to choose. You'll notice that there's not one that says family planning clinic. So it's something that you kind of have to know in order to know. So med services. Date of service is also important if you're trying to research a code for a claim that you're billing back in 2020. You need to keep that in mind and enter the date that you're looking for. Okay, and then the procedure code itself, you saw I put in 99211. The first thing that comes up are the billing rules, and this is helpful. It shows you what the rendering provider types are, what your place of services are, are PAs required, is there a diagnosis restriction? But before I even look at that, I always go down to the bottom here and press show all, and that will bring up the rates, rules, restrictions, and any co-payments. So I press show all, and then you see we have our rates as well as these billing rules. So this is the important part. It shows us who can bill these codes. It's in code, it's in kind of a secret language here, which is the provider type and provider specialty combination. So for example, 16-12 is a nurse midwife. My dog is whining right now. Dappy, stop it, please. Come here. Lay down. Lay down. Sorry about that. Working from home, there's just no way around it. Okay, and the way I know that a 16-12 is a midwife is by going down to the bottom again and clicking provider type and specialty. Code reference. And here you can see a listing of, and of course it's not in order. If I'm really struggling to find something, you can Control F and do 16 and 212 brings it up. So that's nurse midwife. So I'll go back to the fee schedule and go back up to the allowable provider types. And this is something where you're going to have to, come back to the fee schedule when you have time to research specifically what type of provider is going to be rendering these services. So before I told you, besides the description of the 99211 and who is allowed to render it, I can't tell you a whole lot about it because it comes down to what's happening at a clinical level. And that's why having a professional biller is helpful, because they have gone through training that talks specifically about how to choose these codes based on what's happening at the clinical level. Me being a TA, I don't know, and I'm not willing to venture a guess for you as to what code you should use. And so I guess know that up front that I'm not going to be able to tell you what code you should or shouldn't be using. But what I can do is tell you what's allowable. So if you see a provider type and then / a provider specialty, it's going to link back up with that list of the code. Yeah.
There's a question about can that rate / specialty area be set in numeric order by provider type?
No, it can't. It's just listed out. It's not in like a, it's not in a Excel, so no, it cannot. But you can do a Control F. Excuse me. So is that question specifically about, can that, okay, yeah, that's a good idea. I think unless you know, once you figure out what your provider type and specialty is, or what your clinic's provider type and specialty is, that's where it gets a little confusing, because as you can see here, it says rendering provider type and specialty. So on a claim, you've got the billing provider, and then you have a rendering provider. In some cases, the billing provider is the rendering provider. So in the case of a physician clinic, the billing provider is the rendering provider. And because they're allowed to both bill and render, and then you'd see that would be listed here. It would be a 33 something, 33,900 physician group clinic. Now, if you're billing at a facility level, that means you're not rendering, you're putting a individual renderer. And that's different from if you have a billing provider type that is not allowed to render, in which case you have to indicate your specific renderer. If you don't know, then please reach out and let me know. I can tell you exactly who should be in your billing field for the claim, and then who should be in the rendering. And that will give you the information you need to determine whether or not you can provide this code. And thank you for the suggestion. Being able to search this provider type and specialty codes easier would be very helpful. I agree with that. And then you can look down at the rates section, and as you can see, it's broken out by the provider type and specialty, and then what modifiers you are using. And that determines the rate. In some cases, it's broken out by the age as well. The rate type is not necessarily important for you to know. You'll be able to figure out what the rate is based on provider type and specialty, modifier, and sometimes age. And then, excuse me, and then below that, you can see there are a lot of variations that can affect the reimbursement rate for this. And then at the bottom, you can see restrictions, and it says there are no restrictions or none were found. That's misleading because, of course, there are restrictions to how you can bill this code. So don't take that as gospel. Okay, so the next thing that excuse me, the next thing that I wanted to show you is what our backend system looks like when we put in this 99211 code. And it has just, it has basically the same information, just in a slightly different format. So on the back end, we have the description and then the long description. And this long description is very much the same as what is listed in the update. And we have what contracts can bill this. So remember when I said that we're searching under med services, because that's the contract that you as a clinic or you as an individual will have on your file with Medicaid, is this med services. Unless you're a vision provider or if you have these different funding sources. And then we can scroll down to the valid section based on the dates, and we can see pretty much the same information. Provider type and specialty. So when it says 09 and then zeros, that means any provider type 09. And if we go back to provider type and specialty, that is nurse practitioners. So any type, excuse me, any type of nurse practitioner is allowed to bill the 99211 code. We see 10, which is physician's assistant. 14, which I don't know off the top of my head, so I can check this. Podiatrist, that's right. 31 is physician, and 33 is physician group. And then 58 is IMD, I believe, and can just verify that by doing 58. And interestingly, yeah, it's institution for mental disease. And interestingly, there are a couple that are missing from that provider type and specialty list. Specifically, behavioral treatment providers are missing. 16 is the nurse midwife. 16-900 is a nurse group, and that is a group enrollment, so that would be a 2 or more Medicaid enrolled nurses. 71080 is your family planning clinic, FQHC. 083 is just family planning clinic. And so that's where you're going to be, that's where you're going to be seeing to be allowable to bill this code set. And then 72 and 73. And I'm just going through this because they're the same for all the E&M codes. And I know that providers are interested in what is going to be allowable for this. 72, so that's health check. And then 73 is health check other services. And so that kind of goes over who the allowable providers are. If I go up and change the procedure code to new patient, high medical decision making, or 60 to 74 minutes, oh, of course, signs me out. I just want to show you this just so that you understand it's the same set of providers. Well, if it's going to take me time here, I don't want to. Slow system. Okay, so at that, I think we kind of covered the high level of these codes, what they are, who can bill them, and what's changing. I don't know if I mentioned before, for those of you who don't know how it's changing, it used to be done only by medical decision making. And so the addition of the time standard is really what's changing, as well as the codes, the code that is being removed, and then the addition of the prolonged services HCPCS code, the G2212. I want to set enough time aside so that y'all can ask a few questions. A few questions were submitted, and I want to make sure that I did get those. So how to document times, can an RN in a primary nurse-based clinic bill? And then further explanation on when 99211 can be used. So can a nurse bill? Again, it goes back to what is being submitted on that claim. If you're submitting as a family planning clinic and your clinic is allowed to both bill and render, then yes, they're allowed to provide that service, or you as a clinic are allowed to provide that service. It just comes down to how your clinic is set up and how you're billing. So if you have questions on can your current setup bill X code, that's something all you have to do is send me, who's going to be rendering, who's going to be billing, and I can tell you if it's going to be allowable or not. And then a further explanation of the 211 code, which says, and I know exactly what the question is, and it talks about not necessarily needing a physician. So who's going to be allowed to bill that? you know, it comes down to who can provide that service within their scope. And then as a clinic, you're going to be billing the code. And so you have to be able to rationalize for an auditor, you know, and that's really what I think when you're billing Medicaid, you're really billing Medicaid in such a way that when you do meet that auditor from OIG, that you're able to rationalize the decisions that you made in your billing. So are you going to be able to rationalize your use of that code? Did they operate within their scope? Was it something that didn't, you know, break any other rules? You know, if you have somebody that's licensed by DQA or DSPS, are they working within, you know, their licensure? So there's so many questions, variables about who can provide that service that, like I said, I can show you who can bill it, and that's, or I'm sorry, who can bill and render. And that's what I did here. And then from there, it's kind of something you have to determine as a business. So I think I covered the questions that I set out to, and now I'll check the questions that came in while we were going through today's presentation. Loretta, there are no slides. I did not create a PowerPoint. What we can do is send out links to some of the resources that we have. The biggest one here is going to be the update that has links to the CMS documentation guidelines. And then the way that I found the AMA, minimize this, the AMA guidelines and changes was just by Googling it, because as I was doing research. So I suggest doing the same, especially if you don't have a professional biller. It was very helpful in understanding the codes for me. And since we've adopted the federal guidelines, you know, it's not different per se than the ForwardHealth policy. So refer back to the update from ForwardHealth and the online handbooks for the specific policy related to ForwardHealth. You know, but the policy was derived from the federal changes. Okay, so let's see. I don't know. Can 99211 and H1010 be billed together? That's a good question. So the way that I would answer that is by running a test. That's really the only way I know how to do that. Any two combinations of codes. So Chelsea, go ahead and reach out to me. Send me an email and I can do a test on that to verify. And then that's something that I can get back to Megan to share with the team if that's something that's a common billing scenario. I don't know off the top of my head. Too many combinations of codes to know that kind of stuff. Thank you for the question, though.
Kyle, just before I read the next question, I invite everyone to ask their questions in the chat, and we'll go over those ones first. But if you also have a question that you would like to come off mute for, we'll give time for that once we read through some that are in the chat. So a question that came in was, if other states are asking about billing for time, should they ask their MA department?
If other states are asking about billing time, should they ask the MA department? I'm not sure I understand what you mean. If another state is asking, maybe you could clarify what you mean by that. You know, I'm not sure what we're talking about.
Yeah, while that is getting clarified, I'll just go on to the next one. So Someone would also like to know about the 99211 and H1010.
Great. Okay.
There's a couple of people that would like to know that as well.
Okay. Yeah, from my research, I don't recall there being anything explicitly related to the H1010 and any E&M code. So yeah, I think my best bet is going to be to have it just tested. What I'm doing here, if you're curious, the family planning online handbook has a specific section on E&M under the covered and non-covered services. And so I'm just going to take a look here and see if it says that it can or cannot. Yeah, and I don't see that it is. Yeah. So I'll do a test and then I'll make sure that Megan has what I found out and she can send that out to the group.
Yep, we can do that. And then clarity on that one question, which I'll restate the question and then clarity. So if other states are asking about billing for time, should they ask the MA department? And then it was colleagues in other states are questioning how to bill for time.
Okay.
I'm thinking their best source is their Medicaid because they believe you said these changes are federal, which applies to all providers regardless of state.
Yeah, okay. I understand what you're saying now. Thank you for the clarification. Well, I mean, as you know, we adopted these changes later than we could have. And so I think it's important to know that, you know, whether or not it's a federal guideline, whether or not it's been adopted and is current policy is still an unknown. So yeah, they would definitely want to check with their payer, their Medicaid payer, to find out if they've adopted these changes. If they have, then of course they can use those federal resources like the AMA the AMA website as a resource, but they would need to check to make sure that's the current policy for their state first. Is there anything else that anybody, I know we're running close on time. Is there anything that anybody wants me to cover at next week's? I believe that's next week. Is that next week, Megan?
It is. It is next Wednesday, the 3rd of March.
The 3rd. Yeah. So does anybody have anything that they would like me to cover for the 3rd? And I can tailor the training to best suit your your needs as a group. The overall topic is going to be billing policy. And so my plan is to kind of go through what the current policy is for allowable codes and kind of how to navigate the portal to find those answers to those questions you might have on a daily basis operating under the family planning service area. If you want to point me into a specific direction, you know, that'll just make it more helpful for you. And feel free to reach out between now and then with any specific questions you have. Again, that really helps me because then I can focus on what's important to you. Because I don't know. I cover a couple dozen different service areas, so I unfortunately don't know what's most important to y'all.
Thank you, Kyle. And I will include my email address and Kyle's in the chat so that you have that. So if you do have questions for Kyle for the March 3rd date, he can get those directly. And this webinar, as well as next week's, will be recorded so they can be viewed concluding and once they are on the website. And there is a question, when and which modifiers to include on bill with E&M CPT?
Yeah, it's a good question. So the modifiers are something that we do have listed out on the online handbook. So I quickly got there, but again, you're in the family planning online handbook, and then under covered and non-covered, you have codes, and one of the sections is modifiers. These are the allowable modifiers for family planning and anesthesia services, and then also for drugs and supplies. So the professional and technical components, those are those can be confusing to non-billers, and that's something that if you have questions on, you know, what would constitute a professional or technical component, feel free to reach out kind of on a case-by-case basis. Otherwise, they're pretty straightforward up here for the services that are allowable. And as it pertains to the E&M codes specifically, I think, you know, it shows in the oh, not really on that anymore. I'll go back to this other one. It shows in the max fee schedule what AQ and TJ are the modifiers that you know, they're showing rates for. There are also a lot of other modifiers that are informational that may not necessarily change the reimbursement rate. What I can do here is just show you what the description of those modifiers are really quick. So the TJ indicates a program group, child or adolescent. And then AQ indicates a hips area. Chris, thank you for asking, how do we know if it'll affect reimbursement? Or if it will be accepted rather than denied. I'm not sure how to answer whether it'll be accepted or denied. You know, if you're performing a service that requires a modifier, you know, then I don't know how to answer the accepted or denied part. But how it affects reimbursement, you can see that in the max fee rate. So for example, you can go down and see with no modifiers what the reimbursement rate is, and then you can add, you know, the TJ, which is your child one, and you can see how that changes your reimbursement rate. You can add both, see how that changes the reimbursement rate. So I'm not sure. We dispense meds in the clinic that are often not reimbursed. So wondering about the UD modifier. Yeah, UD would not affect, that would not be an allowable modifier for these codes. Right. So, I mean, I do see that. I don't know what your name is. 340B med. So, I mean, when we're talking about the E&M code, I'm not sure how that would. I'm not sure, when you would be using that in conjunction with the E&M code, or if it's same data service. It wouldn't change the reimbursement rate for the E&M code though. The only two that are allowable that would change the reimbursement rate are the ones that are shown here in the max fee. So UD in combination with a either a PAD, a PAD, or some other drug code would change the reimbursement rate. So how would you find that? That would be something where if it is a J code, that is a HCPCS J code, a PAD, that is listed in the max fee, you could search it there. Otherwise, in the drug search tool to find out what the reimbursement rate is. I don't think the drug search tool would be, yeah, never mind, it would be a HCPCS code. So it's something that you would be able to find the reimbursement rate for in the fee schedules. And if you have a question about specifically about a code, a specific code, and you're not sure how to find the reimbursement rate, let me know and I can help with that.
Awesome. Well, it is 1:02, so I am gonna cut it off here. But if you do have any questions for Kyle, I have provided his email along with mine. Please send those along there. And I want to thank you again, Kyle, and everyone who is attending. And there will be an evaluation sent to you via email. And we greatly appreciate your feedback. And my coworker Megan has put that in the chat for you as well if you want to click it open there. And please look out for a thank you email following this webinar, as well as following emails for the webinar that is next Wednesday, March 3rd, for the Family Planning Only Services webinar. So with that being said, thank you so much. And I hope you have a wonderful rest of your day.
Thanks all.